Good evening and welcome to our webinar on the proceedings of interventional clinical trials in COVID-19. My name is Eva van Brakel. I'm a pulmonologist at Ghent University Hospital and your host for today. We'll discuss both the antiviral treatment and immunomodulatory approaches of COVID-19. Questions can be asked through the chat function in the YouTube channel and will be answered at the end of the webinar. Professor Bart Lambrecht is our first speaker, and he's the director of the Center for Inflammation Research at the Flemish Institute for Biotechnology and Ghent University. Besides that, he's a certified pulmonologist and part of our staff at Ghent University Hospital. Bart will guide you through the pathogenesis of COVID-19 to identify potential druggable targets.
Thank you very much, Eva. So, let me just share the screen first. Good evening. So we thought it was really important to also update you a little bit on the basic pathophysiology of this disease, because from this basic pathophysiology, there's a lot of emerging drug targets, both antiviral therapies as well as immunomodulatory therapies. So this is the enemy. It's the SARS coronavirus 2, which resembles the previous SARS virus from a couple of years ago, and also resembles the MERS virus. But it's different from the other ones because it has a different spike protein. And the spike protein is actually protein that the virus uses to get into cells. So I think by now, a lot of clinicians certainly already have a pretty good feel of this disorder. And suffice it to say that the stage 1 of the disease is mainly characterized by a viral response. It's a typical viral infection where the patient has myalgia, has fever, and feels generally ill. And then in a subgroup of patients, as this viral response goes away, there's a second phase of the disease where there's progressively more respiratory symptoms. People will start coughing more, they will start feeling shortness of breath. And this stage of the disease is now divided in 2 stages, 2A and 2B. And 2B is characterized by severe signs of hypoxia or shortness of oxygen in the bloodstream. So in even the further minority of patients, there can be a further progression of the disease into stage 3 of the disease, where we really speak about a hyperinflammatory response, where people will have liver function abnormalities, will have signs of ferritin increase, etc., sometimes referred to as a cytokine storm. And in this later phases of the disease, I would say from stage 2B onwards, this is in fact the immune system that is overreacting, whereas in the first phase of the disease, the viral response, your immune system is good because it's helping you to protect from viral replication. In later phases of the disease, the host immune response or our own immune response will actually be harmful to the lungs. And progressively, there is more damage happening in the lungs. And you will see here across the board, and the next speaker, Stephen Collins, will talk about this. Across the board, we can use or have been using medications. But the point we want to make today with this session is it really matters when exactly you give which type of intervention strategy. So this is bringing us to the pathophysiology of the disorder, and this is how the lung looks like under high magnification. It's a sketch, of course, and you have a typical alveolus here with a terminal bronchiole here, and the main function of the alveoli is gas exchange. And gas exchange happens across a very thin alveolocapillary membrane, which is in fact only 0.3 micrometers in thickness to allow oxygen and CO2 to be exchanged. So you can imagine with such a thin barrier that it's very easy for a pathogen that is inhaled, for example, here in the alveolus, to breach that barrier and end up in the bloodstream. That's really dangerous. So our lung has to defend itself very well. And it can defend itself, the lung, by having an acute inflammatory reaction, very typical, a pneumonia reaction. But this reaction needs to go away immediately, because if it stays for too long, your gas exchange will be compromised. So it's always very hard to defend the lung. There's easy pathogen entry, but you cannot allow too much overt inflammation to happen. And there's a very important cell type in our lungs that controls this delicate balance between defense and oxygenation. It's the alveolar macrophage. The alveolar macrophage has been compared as a vacuum cleaner of the lung. It's a cell that will typically ingest all kinds of pathogens like viruses, bacteria, but also dust or cigarette smoke particles, and it will get rid of that. It will neutralize those triggers without causing inflammation. It's really like a vacuum cleaner. The alveolar macrophage does another thing very important. It's to maintain surfactant homeostasis. Surfactant is the detergent that keeps our alveoli open. And without alveolar macrophages, you will have alveolar collapse. You will have atelectasis. And this is actually very bad for gas exchange. And then the third thing that happens in the lung is that the alveolar macrophage will keep all the T cells that come into the lungs in a steady state organ. It will dampen those T cells, keep them in check. And this is probably something very important for COVID-19, where we see a lot of influx of T cells coming into the lungs. So normally, an alveolar macrophage should be dampening those T cells in an anti-inflammatory effort. So what happens in early infection? So when the virus comes in, the virus can infect bronchial epithelial cells. It can infect alveolar epithelial cells, causing a lot of damage to the alveoli. Here you will see that the basement membrane here is injured. It will infect alveolar macrophages, the vacuum cleaners, and it can, strangely enough, also infect endothelial cells, capillary endothelial cells. So the next speaker will go into detail on this slide much more, but suffice to say that the SARS coronavirus enters the cell via the ACE2 receptor, then it will need to be released in the cytoplasm in an acid compartment, injecting its single-stranded RNA into the cytoplasm. This leads to protein production, and then new virions will be produced. This will be the topic of the next talk, because we can deduct a lot of therapeutic antiviral drugs from this general scheme. So when this RNA of the virus is released inside infected cells, the innate immune system will kick in. And this innate immune system is typically organized, again, by the vacuum cleaners, by the alveolar macrophage. So the alveolar macrophage will produce cytokines like TNF-alpha, IL-1, IL-6, and those cytokines will lead to more recruitment of phagocytic cells like neutrophils and some eosinophils. Another cytokine response that is very crucial in the early phase of the disease is the so-called type 1 interferon response. Now, every viral infection in our body triggers a type 1 interferon response, and type 1 interferons can even be used as a therapeutic strategy for viral infection. Think about hepatitis C virus, for example. So this type 1 interferon is very important because it puts neighboring non-infected cells in a so-called antiviral state. And we think that in elderly people, this type 1 interferon response is defective. It might be one of the reasons why we see so much infection in the nursing homes. It's because the elderly people produce less prominent and less rapid type 1 interferon responses, allowing the virus to replicate more and to cause more damage in the acute phase, in the early phase of the disease, leading to higher fever. And in this particular vulnerable population with comorbidity, this can lead to early mortality. But sometimes it goes terribly wrong in patients and they go into this second phase of the disease. This is a CT scan here of a patient who was referred to us. The first presentation at the 5th of April, you see some mild ground glass opacities, and you clearly see there's a bronchocentric distribution. The patient has inhaled this virus and it ended up in various segments of the lungs, but you have a little bit of ground glass opacity. And then all of a sudden, 5 days later, you have a white lung, which looks really, really devastating. This patient had a CT score of 21 out of 25 when he arrived here in the hospital. So within 5 days, this disease can go terribly wrong. So what is happening in some patients? So it's particularly this phase, you know, when people are start to become hypoxic. This is where we see this host inflammatory response shooting up. And it's as if the immune system thinks there's still virus replication, but in fact, we have the hardest time in those people trying to find high viral loads. The viral load is quite low at this stage, but it's really the immune system that's fighting the virus that's causing these white lungs. So what is the pathophysiology of those kind of reactions? So I will go through the different steps of this. So when the virus comes in, it's going to infect the endothelial cells, causing microthrombi in the small capillaries of the lungs. And there's going to be release of bradykinin. So bradykinin is normally metabolized by angiotensin-converting enzymes, but we lose those enzymes because the virus uses the enzyme for entry. So there's a rise in bradykinin, and bradykinin can cause contraction of the capillaries here in the lungs, and this will cause a massive capillary leak, leading to alveolar edema, exudation of plasma, and really almost like flooding of the alveoli. And this is what you see in those early stages of ground glass opacity. So the ground glass opacity is mostly caused by capillary leak and early inflammation, I would say. The neutrophils that are recruited will also contribute to this capillary leak because they produce reactive oxygen species. You know, and we know, and particularly ICU doctors know, that you always have a delicate balance. If you have acute lung injury, you want to increase the oxygen fraction, but the more oxygen you give, the more oxidative damage you can cause. So it's always very delicate, and you have to be sure that you don't give too high of an FeO2 for too long in those patients with acute injury. So what will also happen almost immediately with that capillary leak phenomenon is that there's going to be release of tissue factor, which is the initiator of tissue thrombosis, tissue coagulation. You will have thrombin formation and fibrin deposition. And the fibrin will start being deposited on the damaged basement membrane of the alveoli, and this is called hyaline membrane formation. And those hyaline membranes are nothing else but fibrin, dead cells, and all kinds of debris that ends up in this inflammatory reaction. And that debris will immediately be degraded again through a plasmin reaction, anticoagulation. And this is the reason why you start seeing D-dimers at this phase of the disease. It's a very important prognostic sign. If your D-dimers start going up and there's no pulmonary embolism going on, when the D-dimers go up, it's actually a sign of beginning diffuse alveolar damage and acute lung injury. If this further progresses, you will also see that the CRP, which is our traditional biomarker for bacterial infections, CRP is massively produced in this stage of the disease. And the CRP is much more than a biomarker. CRP will deposit in the alveolar damage. It will activate complement C2, leading to complement activation, C3A and C5A. And then we actually go into full-blown diffuse alveolar damage. The C3 and the C5A will recruit an absolutely overdrive of inflammatory cells with a lot of neutrophils, a lot of pro-inflammatory monocytes that actually replace all the vacuum cleaners. So your macrophages go away and everything gets replaced by inflammatory cells, including monocytes. And those monocytes produce IL-1, IL-6, TNF-alpha, and this is the so-called cytokine storm. So according to our view here in the hospital, the cytokine storm in this particular form of lung injury starts in the lungs. It's not a reflection of something that happens outside of the body. It starts in the lungs and then it spreads throughout the body, giving rise to all kinds of biochemical alterations, such as ferritin increase, etc. So where are we going with this kind of injury? And I think in Belgium, we're not at this stage yet. So any diffuse alveolar damage can lead to fibrosis. So how is this initiated? So when the damage is very severe and there's a continued deposition of fibrin and debris in the lungs, your type 2 epithelial cells, which have stem cell potential and have a potential to regenerate or restore an alveoli, those type 2 epithelial cells have nowhere to go because the basement membrane is occupied by debris. And the type 2 cells, you know, they start proliferating, Normally they spread out very nicely along the basement membrane, but now they have nowhere to go. They start, growing and growing. They make TGF-beta as part of their normal program, and this leads to fibroblast activation. And fibroblast activation is the beginning of fibrosis. And initially, this is all reversible. The fibroblasts can even grow into the alveoli, causing so-called cryptogenic organizing pneumonia or BOOP reaction. And this can completely white out the lung. So part of the organization you see in the later phase of COVID-19 on the CT scan, which we call consolidation on CT scan, is already those signs of cryptogenic organizing pneumonia. All of this can still be reversible. Some of it might be steroid sensitive. It's too early to say that that is the case. It could be that we have to wait until the complete viral phase is over before steroids would be safe in this disorder. Several trials are running. However, even with those fibroblast foci, in some patients, you can have complete restoration of diffuse alveolar damage. We all know, that a complete white lung, a pneumonia, a lobar pneumonia, for example, if you wait long enough, can completely clear. Some people will have fibrosis, some people will clear it. And when you clear it, it's again because the monocytes that have come in under the influence of GM-CSF, which is made by lung epithelial cells, will differentiate into alveolar macrophages, vacuum cleaners that will actually completely clear out the debris. And when the debris is gone, the epithelial cells can restore the alveolus, and gas exchange can completely return, and radiology can normalize. So in conclusion, for this part of the talk, there's several drug targets we identify through this. There's viral entry and replication, topic of next talk. There's cytokines we can antagonize. Complement plays a role. Coagulation needs to be kept in check. The bradykinin pathway is there. And we can try to promote repair and prevent fibrosis. So I think, Steven, you will talk about the next part, right?
Thank you, Bart, for this inspiring introduction. Our next speaker is Professor Steven Collins. He's the head of department of the General Internal Medicine and Infectious Diseases at Ghent University Hospital. And Steven will guide us through the antiviral strategies, and he knows that it's all about timing.
Indeed. Good evening, everybody. So it's all about the timing of your antiviral strategies, and with the explanation that Bart just gave, you will understand that the antiviral strategy should begin at the start of the infection. And indeed, Bart has shown this picture already, and as an infectious diseases specialist, I'm obviously interested in what was written down here. Now you can see that this antiviral therapy, which was proposed in March of this year, is put throughout the slide throughout the course of the disease. But I think that we might have to review that in timing our antiviral strategy in these patients. Bart has shown this slide already also. There's several drug targets that have been identified, and there has been many drugs that have been repurposed for this matter through AI, through testing. In Leuven, they do a lot of testing of old drugs, repurposed drugs, as we say, and that can be used in the infection with this SARS-CoV-2. The first is camostat mesilate, which is an inhibitor of the TMPRSS2 co-receptor factor that allows the virus to enter the cell. Obviously, we have all learned about the chloroquine and hydroxychloroquine that can help reduce the viral load through alkalinization of the cell, but also the immunomodulatory effects that it has. We have access to HIV antiretroviral drugs that then will block the protease within the cell. And then we have the obviously directly acting antiviral drugs, which have been around for a very long time, such as ribavirin, but especially remdesivir and favipiravir, which have a more generous or better toxicity profile than ribavirin. There's also other drugs that have been identified recently, such as ivermectin, which is already in trial in Brussels, in use at Brussels, and then itraconazole, which also works on a different mechanism, which is under trial in UZ Leuven already. So a lot of exciting new developments of old drugs that can be repurposed and are quite cheap to form. But we really have to think about when we put these antiretroviral drugs into use. When a person gets exposed, he gets infected, there's an incubation period that happens in which the patient is still not infectious, but also asymptomatic. And as soon as the symptoms arise, obviously, there's a very rapid increase of the viral load within the patient. Usually, these are the patients that will be seen in first line, that may be seen in the emergency wards, but that may not be hospitalized at first. In the second phase, there's a deterioration, and then the patient gets hospitalized before he gets into this bad inflammatory response and needs to be admitted in the ICU. And so the windows of opportunity that we have within this viral disease to stop it, especially for the antiviral drug treatment, maybe in the beginning, while in the latter stage, the immune modulatory response or treatment is far more important. However, the hospitalized patients we see during a very short time period in which we have to choose this therapy, either combine it or go for immune modulatory treatment as is. So in short, I would like to say that for antiviral treatment, I see a use in PrEP, I see a use in PEP, and several trials have been ongoing now in healthcare workers and in communities populations. But in treatment, either we have to hit early and we have to hit hard, or we'll have to go to immune modulatory treatment to avoid all the complications that Bart just came to talk about. Now, what is the potency and timing of antiretroviral therapy in terms of duration of infection? This is a modeling study that was done. It was a modeling study that was done with chloroquine and remdesivir. I'm only showing some of the graphs of chloroquine, but the remdesivir story was quite similar. And so what you see in these four graphs is in the first graph, what happens when you put when you start the hydroxychloroquine treatment after 10 days of symptoms. And after 10 days of symptoms, you can already see, as Bart has said, that this viral load is going down. There will still be some viral replication, but the influence that you have depending on the potency of hydroxychloroquine, and again, this is a modeling study, so it's pure mathematics, but depending on the potency that you give to this hydroxychloroquine, you will see a slower or a faster decline of this viral load. But remember, we are 10 days within the infection. If you stop within 5 days, you can see that the more potent the treatment is, the faster the viral load will reduce, but you will still have a decent amount of virus within the body and within the lungs especially. So you need to start early. You need to start very early with antiretroviral treatment. And if you start early, you might avoid infection completely. However, you might also, and especially if the antiviral treatment is not potent enough, you might reduce the viral load and extend the infection, maybe do some immunomodulation, but there is a risk that the infection will progress. A second problem within very early treatment, and Bart will talk about that in a moment, is that your immune response, and we know that from HIV, as you get exposed and you take PrEP, for example, you will never develop antibodies, or you may develop suboptimal antibodies, which in the end might be enhancing antibodies and indeed increase the immune response in the lungs. So those are things we need to think about when we time those antiviral drugs. Yesterday, I took the liberty of looking on Clinicaltrials.cov and the WHO landscape of therapeutics, and I counted the amount of trials ongoing. There were more than 300 trials registered. Now, there's some sites where you find up to 600 trials, but I used Clinicaltrials.cov, which is a trusted site. And I counted 103 compounds, of which only 26 are antiviral drugs. So it already goes to say that that immunomodulatory regimen is probably far more important than the antiviral drugs. The most promising drugs are hydroxychloroquine, remdesivir, camostat, ritonavir, especially lopinavir, but both are protease inhibitors, azithromycin, ivermectin, itraconazole, and then favipiravir, of which some I will discuss a little bit further. Now, I've adjusted the titles of the slides according to my own scaling scheme of level of evidence, some trials, one trial, and expert opinion, just to go and say that the evidence that we have for this antiretroviral treatment, whether it's chloroquine or up to azithromycin, is not very solid, but we have to do with what we have. These are some of the early trials that were published. And so the most publicized trial was the one in France of Didier Raoult, in which first he published on 36 patients and 80 patients in 2 treatment arms, in which he said that there was a substantial decrease in viral load when giving chloroquine, and when added azithromycin, there was even a more rapid decline. There were a lot of comments on these studies in which I will come back. So the evidence of this trial was not very high. There was a letter to the editor of a Chinese study which claimed to have included more than 100 patients that says that in their trial they saw inhibition of the exacerbation of pneumonia. The viral clearance was faster, and it shortens the disease course, but the original paper or the original study data have not been published so far. And there were 2 other trials from China which indeed say a little bit of the same. In 62 patients and 150 patients, that the time to recovery was shortened, and there was a more rapid improvement of the pneumonia. In the last trial, there was also some indication that the recovery of lymphopenia was better using hydroxychloroquine. However, in the course of the last week, 2 other studies have been published. The chloro-COVID study, which actually had to stop enrollment after 81 patients. And this was a study looking at higher dosing of hydroxychloroquine, showing that there was more QTc prolongation, and there was a trend towards higher lethality in this Brazilian study compared to the lower dosage. Case fatality rate was 13.5%, same as in historical controls. And so the authors concluded that a higher dosage of chloroquine, 12 gram total dose over 10 days in COVID-19 should not be recommended. Plus, they stated in their study that there's no clear evidence of more rapid clearance of the virus in higher doses. The last study on chloroquine is on the review in the New England Journal of Medicine, and this looked as a quasi-randomized comparative trial in 63 patients. And these authors asserted that hydroxychloroquine in the end was associated with a need for escalation of respiratory support. There was a worsening neutrophil to lymphocyte ratio compared to the supportive care alone, and there was a higher risk of intubation. So the jury is still out. Now, personally, I think there are different inclusions, or the inclusions in the studies happened at different time points, which might be why we see this mixed picture. For lopinavir, ritonavir, there's only 1 trial that has been published. Several are still ongoing. I can be very short and brief in this one. In hospitalized adult patients with severe COVID-19, there was no benefit observed of lopinavir, ritonavir treatment beyond the standard of care. So for now, this is not a drug that has shown any effect. There's an observational trial of remdesivir that was published. Gilead published this in the New England Journal of Medicine just before the weekend. It's a non-comparative trial. They didn't compare to historical controls even. It was their first experience with expanded use access program that they have. And they presented the numbers very nicely in this table, in which they looked at the different ordinal scales, the WHO ordinal scale for grading severe the COVID disease or grading COVID disease. And what you see is that very few patients were indeed included, very few patients were included in the lower ordinal scale, and most of the patients were included when they already had a need for respiratory support. And in these patients, the advancement of the disease was much clear, and the evidence of the remdesivir was low. On the azithromycin, I will go very fast. I think the study of Didier Raoult was severely flawed. Even the follow-up study was flawed, how they published it. And a small study of Molina that came later could not repeat the results of Didier Raoult. I think the jury is still out. There is definitely in vitro data on azithromycin, but these studies need to be repeated to be widely used. There's other things to consider in the antiviral treatment, in that hydroxychloroquine, for example, has lots of side effects, and the QT prolongation is one of the most important that we can mention, but also the interaction with other drugs. And so it's in experience in this center that if you use hydroxychloroquine, that the sedation is much more difficult in these patients, and much higher doses of these sedative drugs need to be used. Lopinavir, ritonavir is the same. Besides the cardiac conduction abnormalities that you can see, there's also important gastrointestinal intolerance. And for example, diarrhea is an important one. And we all know that the virus can be found in feces. So having diarrhea is probably not a good idea during a COVID infection. And also here, lots of interactions that can happen. So use this drug with care. Remdesivir has a safer profile. Elevated transaminases and kidney injury are reported, and is not does not have severe interactions. And with azithromycin, there is a QT prolongation. So if you're going to combine drugs, beware of the QT prolongation, and then also the interactions with azithromycin are a little bit less. Several trials are ongoing in Belgian centers. Leuven, as I said, does itraconazole. Azithromycin is also being used in Leuven. Brussels does a trial on ivermectin, and then Gilead Sciences has made remdesivir available in some of the centers. And I would like to almost end this talk with the Solidarity, the WHO Solidarity trial, in which a lot of the centers are participating. It's a five-arm trial for remdesivir, lopinavir, ritonavir with interferon, and then chloroquine or hydroxychloroquine. It's a very easy trial to enroll with not a lot of data that needs to be entered, easy randomization with endpoints, all-cause mortality or duration of hospital stay. There's no specific sample size. It's a multi-country, and I think they want to collect as much data as they can. And it's an adaptive trial, so if new data arises, they might add new arms. So in conclusion, I would like to say that the data so far has not been very strong. However, the absence of evidence is not the evidence of absence. So I'm not promoting to stop all of these drugs, but I'm promoting to use them in the right timing at the beginning of the infection. Use the Sensano interim guidelines to guide you. And if you can, enter a trial so we can add more to the data that now is still too few. How to avoid a Tamiflu conundrum. Ambulatory trials should be done, and several trials are ongoing, and Leuven is planning to start a big trial on that. I think we should use biomarkers to see how to guide treatment for us, and set up more trials, maybe not multi-country, but at least within Belgium, multi-arm, multi-stage trials. And I would like to end that if we do trials, we have to make sure that the drugs can be made available even after the trial. If we have good data, power should not be compromised, and especially safety should not be compromised. We shouldn't do anything that comes into our mind, but base it on solid data, as Bart will now continue.
Thank you for this excellent overview, Steven. For the next talk, we'll switch again to Bart Lambrecht, who will zoom in on the immunomodulatory approaches to tackle COVID-19.
The first strategy I would like to discuss is this idea that we could try. Thank you very much. The first slide I would like to show is the idea that we might try to repair lung injury using growth factors. So where does this idea come from? It's actually stemming from the fact that one of the major cytokines controlling homeostasis in the lung is GM-CSF. Some of you might know GM-CSF from the old days when leucine was given to patients with neutropenic fever, post-chemotherapy and post-radiotherapy. But GM-CSF is actually a very crucial cytokine in the lungs. The only cell in our body that depends on GM-CSF for development is the alveolar macrophage. And we know now that the virus leads to a reduction in GM-CSF production in the lungs and in the serum. So it's like the virus is trying to subvert the function of this vacuum cleaner in the lungs. And on top of that, the lung is full of newly recruited monocytes that are pro-inflammatory. So the strategy we thought we should try is to actually give excess GM-CSF. So why do we think this is necessary? This is a bit of a complicated slide, but it's a so-called single cell analysis where all the gene expression in single individual cells is measured and then plotted in a simple 2D plot. But you will see immediately here in healthy control, you have, and this is bronchoalveolar lavage fluid from the lungs of patients. You see here group 4 cells. These cells express this particular gene here. It doesn't matter, fatty acid binding protein. But this population of cells is severely lacking in patients with COVID-19 severe disease. And you see that this particular gene here is completely absent from the bronchoalveolar lavage. So what are those group 4 cells? They are alveolar macrophages. So COVID-19 is a typical disease where the vacuum cleaner disappears and is replaced by a pro-inflammatory monocyte. So what we thought we should do, and this is the first trial we would like to discuss. It's currently running in a few centers here in Belgium. It's a so-called SARPAC trial. It's sargramostim in patients with acute coronavirus infection, COVID-19 infection. The idea is to give an excess of GM-CSF because the virus is subverting it, and to give that excess of GM-CSF only locally via the lungs so that it hits the target organ and can have its beneficial effect on monocyte to alveolar macrophage differentiation so that these macrophages can do their function and clean up the debris. So we're giving this drug not at the stage when people are already in the ICU. We give it in the vulnerable time window where there's the beginning of hypoxia and where people are on their way of progressing to the ICU. So the primary endpoint is in fact trying to improve oxygenation in the lungs and trying to prevent people from progressing to ICU uptake, because that's really the bottleneck for hospitals. It's not so much the number of beds we can fill, it's the number of ICU beds we should keep empty, you know, and if we can prevent ICU admission, that is going to have a real good impact, maybe not for this epidemic anymore, but when this would come back or for other epidemics in the future. So how does the trial look like? It's people with hypoxia. We'll come to the inclusion criteria later. People with hypoxia who are on a specialized isolation ward, and they are randomized to receive either 5 days of inhaled GM-CSF or best standard of care. And then after this 5 days of inhalation with a mesh nebulizer, the people that progress, that end up in the ICU, have the treating physician has the option to then switch to IV GM-CSF, and also in the control group, because the primary endpoint is already measured by then, the people in the control standard of care group, should they progress to more severe disease, have the option to get IV GM-CSF, but this is all at the discretion of the treating physician. So it's not controlled by or prescribed by the protocol anymore. So where does the idea of inhaled GM-CSF come from? It's been done before. GM-CSF can be safely inhaled, can hit target when you inhale it. Some people believe it's impossible. You know, it's like you would be inhaling insulin or something, which is also a protein. Nevertheless, it's perfectly possible to inhale GM-CSF. This is a New England Journal paper that came out last year, where they gave it for 12 weeks to people with severe interstitial lung disease, characterized also by lack of alveolar macrophages. This is called pulmonary alveolar proteinosis, where people have autoantibodies against GM-CSF. And this neutralizes the GM-CSF, and they get this severe lung disease. So how does it look like? We're using a mesh nebulizer. This is something that is a very gentle aerosol generator. It's battery fueled, so it's very easy to clean and decontaminate also afterwards. And I'll show you the video here of a test subject taking, inhaling the mesh nebulizer. You see that there's a minimal aerosol upon exhalation. The majority of the drug is actually inhaled. And I think this is nowhere the spillage or aerosol generation you have when you're using a jet nebulizer, for example. I have to state we have to be very careful with aerosol procedures in this disease. And we, at the UZ, we do it in negative pressure surroundings. So the rooms are on negative pressure, but other hospitals allow self-administration of the patient on a regular room. But then the precaution is to use FP2 masks for your personnel and to not enter the room for 1 hour after self-administration of the drug. So far the trial is going quite well. It's been started at 26th of March. There's now 35 patients enrolled in the trial. And there's 3 more that are going to start in the coming week. And we are picking up some nice signals. So this is here the normal eosinopenia you see in those patients. In the white bar, in the white symbols here, you see people who are on standard of care. You see the eosinophils are quite low. But if you inhale leucine, the eosinophils start going up again. And GM-CSF is in fact a growth factor for eosinophils. And it's showing you that there is target engagement, that in fact, even with inhalation, you stimulate eosinophilia in the peripheral bloodstream. So we also have some very nice signals already on improved oxygenation. It's a little bit early to say. We're waiting for an official interim analysis next week because, you know, if the results are positive, this will have implications whether we go on or not with the trial and if it's still ethical to go on with the trial. But more to come next week on that trial. But suffice to say, it's looking good so far. So the next trial I would like to discuss in the next strategy is trying to interfere with the cytokine storm. And throughout the world, there are several things that have been launched. I think what's unique in our setting is that we're not just blocking interleukin-6 like many people have tried, but we're actually comparing blockade of IL-1 with blockade of IL-6 and blockade of IL-6 receptor. So we have 3 different cytokines, and then we also combine those strategies. We chose very deliberately not to block TNF-alpha because TNF-alpha is not only important for a cytokine storm, it's also very important for antiviral immunity. So if you block TNF-alpha, your cytotoxic CD8 T cells won't kill a virus anymore. So that's why we chose IL-1 and IL-6. And there was another practical reason. It's because those cytokines are, of course, very well-known drug targets for treatment of rheumatoid arthritis. So they were available, those drugs, although we had the hardest time purchasing the study medication for our patients. So this is how the study looks like. It's an open label randomized trial in 342 patients across 10 centers. Again, here we're going to expand it to 15 centers in the coming days, but there's a lot of paperwork involved, as you can imagine. The money from this trial comes from the Federal Agency for Drugs, or KCE. Frank Hulstaert was very instrumental in designing the statistics and the buildup of the study. And what we're actually doing is we're making combinations or single treatments, either of usual care, anakinra, which is an IL-1 antagonist, siltuximab, it's a pure anti-IL-6 molecule, combination of anakinra and siltuximab. And then we have IL-6 receptor blockade and IL-6 receptor blockade plus anakinra. So these are very, very high numbers of patients. There's a 2 out of 9 chance that your patient ends up in the usual care group. But nevertheless, you know, we thought it's really important to be all-inclusive, to have a lot of centers here, but we're also a bit limited by the practicality. This is a formal clinical trial design, you know, by the federal government. So we just cannot keep on adding centers to this trial if we are to reach results and definitive good quality data. So I want to close by just showing you one patient that, again, it's the same patient that was referred to the hospital specifically for enrollment in the trial. So it is this patient that rapidly progressed within 5 days to almost a white lung. And you see here, actually, you see it coming already in the days prior to this blackout. So you see the CRP goes from 40 to 78 to 201. The ferritin from 700 to 1200 to 3800. The LDH goes from 200 to 450. The D-dimers from normal to 1100. The lymphocytes drop, and very ominously, the eosinophils drop. So it's very typical in this disease. If you have low eosinophils, low lymphocytes, that's a very, very bad prognosis. So I'll run the CT scans of the patient on the first day, 5th of April, the 10th of April, and you see how devastating this disease can run its course when it's running its natural course in some patients. I'll run it again. So this patient, after 5 days, had a CT score of 21 out of 25, which means that only about 15% of normal lung is unaffected. And we got him referred on the evening of April 10th. He was randomized the same evening by Cédric Bostils, who's one of the study doctors on this trial. And then a patient luckily was put into the tocilizumab arm, and he was immediately intubated. I'll explain later why he was intubated. And you see, this is the administration here of the tocilizumab or anti-IL-6 receptor. And you see an immediate drop in the ferritin levels, the CRP levels, the LDH levels. The eosinophils start returning. This is all over the course of 5 days. The lymphocytes start going up again. The monocytes go up. And the procalcitonin, which we take here as a precaution because people are on anti-IL-6, the procalcitonin shows no signs of bacterial infection. On the contrary, the procalcitonin is even going down in this particular patient. So the good news is that this patient was extubated already after 3 days in the ICU here in the K12 building. So patient was extubated, and this is the CT scan taken this morning. So you will see that there's already strong reduction in the degree of CT score going down. I mean, the regions that were originally affected are still visible, of course, but you see that there's much more aeration already in this patient. And I saw the patient yesterday evening. He was having his dinner as if nothing happened. He's a little bit shocked by the stay at the ICU, Eric, but most people are, I think. But this patient is doing really fine. And just to show you what the impact can be of blocking a cytokine on oxygenation in the lungs. So I want to remind you that we're not treating the cytokine storm, we're treating a lung disease. So if it's going to work, it's going to affect oxygenation in the lungs. And this is what you're seeing. So 5th of April, when he first visited his hospital, the AA gradient was 30 millimeters mercury. The normal age expected is 18.5 millimeters mercury. So there's a mild VQ abnormality, a mild diffusion disorder. By 5 days later, when the lung is blanked out, I would say, the AA gradient is 245 millimeters. That's why he was intubated also. The age-adjusted and oxygen-adjusted AA gradient is 33 at that point. So this patient has a 740% value of his AA gradient. He's then intubated, put on anti-IL-6 therapy. And now, yesterday, he had an AA gradient of 33 millimeters mercury, showing that oxygenation and VQ abnormalities have largely been restored over the course of a few days. This is a case, of course, but this is why we do this study. I mean, we saw from the reports in Italy and in China that this might be working. They used it in patients later in the disease, you know, when they were already a couple of days into full-blown ARDS. But I think we should really do it earlier. We should do it in phase 2B, maximum maybe 24 hours of ventilation. This is also how the study protocol is. And this can have dramatic effects with a single shot. It's a single IV shot of an anti-IL-6 drug in a dose that you normally use for a rheumatoid arthritis patient. So to conclude, I can also forward these slides to the physicians who are listening. We have the two trials, the SARPAC trial and the COVADE trial. One, they're both aimed at people with hypoxia in phase 2B of the response. The big discriminator is, do you have signs of a cytokine storm or not? If you don't have signs of a cytokine storm, so the ferritin levels are low, we can put people on inhaled GM-CSF. If you have an active cytokine storm, we put those people in the COVADE trial, providing they meet all criteria. And we have pretty strict defined criteria defining a cytokine storm. So it's running now in 10 centers, and we currently have 19 patients enrolled, and this was this morning. So I want to conclude by showing you the team of people who put this all together in basically in 6 days. We built the first SARPAC trial. You know, from idea to first patient, and then the COVADE trial was built also in like 5 or 6 days. So this can only work with an oiled machine, and this oiled machine was the Hirus here in Ghent. The pharmacy was very important for getting the drugs here. Our direction had to pay the study medication when nobody believed in it. It was 900,000 euros by the way. We have a study team here at Pulmonary Medicine who helped me enormously with setting up all the practicalities. And then we have a team of 5 study doctors who normally work, who are doing a PhD actually. They're all medics in internal medicine or ENT, and they dropped all their basic science work to do all the patient data registration and informed consents, etc., etc. So I really want to thank them for doing this, and I think it's really in the benefit of a lot of patients. Thank you very much.
Thank you, Bart, for sharing these promising data with us. Then it's time for a Q&A session for this panel. We also have Professor Erik Hoste from our ICU department who will be joining us to cover some ICU-related questions. And I already have a first one here for Bart from Sofia Mascalidi. Would the administration of JAK inhibitors help alleviate the cytokine storm in COVID patients in combination with other treatments?
I think, Sophia, that's a very good question. So there is one trial, at least, that's in Clinicaltrials.cov, where they're trying to use baricitinib. So it's a rather broad JAK inhibitor. I think it's also hitting TYK2, actually. Which basically means that you're also subverting type 1 interferon signaling. So you have to be very careful. You know, you can block IL-1 and IL-6 signaling and even interferon gamma signaling with a JAK inhibitor, but you have to be very careful to not subvert type 1 interferon signaling. So we're currently testing it in the test lab, in the animal lab, with another virus model, with a positive stranded virus model. but we're still a little bit on the safe side. It's certainly a possibility, and several groups are thinking along those lines.
Thank you. The next question is one for Steven, I presume. What's your personal experience with remdesivir?
Well, within the, this COVID epidemic, unfortunately, we haven't been able to get our hands on remdesivir, but we have used it for other antiviral or viral diseases, and we used it in the measles case in an immune suppressed patient who was unable to clear the vaccine. It was, as said, quite well tolerated with some elevation of liver function and some small kidney function decrease, but which reversed after we stopped the treatment. Now, this was a patient that didn't have cytokine storm or any inflammatory reaction. So we were able to monitor the measles load, viral load, and this disappeared with the drug. So yes, we have good experience. Unfortunately, not within this epidemic, but then I know that Gilead is ramping up their production of remdesivir seriously. And so hopefully we'll be able to use it in future within this epidemic.
Okay, thank you, Steven. Another question for Bart from Sjoerd Schetters. What would block blood eosinophils in such a radical IL-6 dependent way? Are there patients with normal eosinophil counts?
Yeah, I think, yeah, I'll wait until, yeah, Sjoerd, thanks for your question. I know you're an eosinophil guy, so I have to be careful what I'm saying. Yeah, so it is indeed an IL-6 dependent manner. And there is some emerging work from a group in Liège that in fact IL-6 has an inhibitory effect on eosinophil poiesis. So it might be something that we're directly restoring by blocking IL-6. Nevertheless, it could also be an indirect effect. You know, eosinophils can be part of the hemophagocytic syndrome where they've been eaten, when they're eaten by monocytes. And then finally, there's also some evidence that type 2 immunity seems to interfere with the ACE2 receptor. So it could also have to do something with, you know, a propensity for type 2 immunity. There might be subtypes of patients who have higher eosinophil counts. In China, they have claimed that low eosinophils are bad prognosis, but it could be in later stages of the disease when we are already in this organizing phase, you know, where you get the COP reaction and the BOOP reaction, where the fibrosis starts to kick in. There, actually, the eosinophil might be bad. So the jury is still out, I think.
Okay. Then I have two TNF-alpha blocker related questions. One from Linda Grine. Though it makes sense not to treat with anti-TNF for too long, blocking TNF can in fact increase TLR7 induced type 1 interferon production. Would it then be useful to use anti-TNF in the early phase?
Well, that's a tough one, I think. I mean, it's like always with cytokines, it's going to be a balancing act. And, you know, a cytokine can do harm at one stage of the disease and be beneficial at the other stage of the disease. We had to make choices. And for us, we were mainly led by the fact, you know, that TNF-alpha is quite important for cytotoxic T cells. Unleashing the type 1 interferon could be beneficial in that respect, if it's really true in the early phases, could be beneficial. However, there's also options, you know, in the Solidarity trial. There's one of the arms is actually giving systemic type 1 interferon as a strategy. So I'm not so sure if you necessarily need to block TNF-alpha to get a raise in type 1 interferon. I would say just give type 1 interferon then, if that's your point.
Okay. Then Professor Jo Lambert has a question also on biologicals. She has the first impression that patients on biologicals such as anti-IL-17 and anti-IL-23, even anti-TNF, for underlying diseases such as psoriasis or IBD, do not show severe COVID-19 infection. Could that protect them from COVID?
Again, hello, Jo. That's again a very good question. So I think it makes sense. You know, there's some studies from the MERS epidemic that and from MERS animal models that blocking the IL-17 pathway, for example, can be beneficial for the severity of the ARDS that you see in those animals. Those are then transgenic, humanized animals. So I think your observation might make sense. I mean, it's also partially already addressing the previous question. You know, if a TNF blocker is given, maybe it has some beneficial effect. You know, but again, you know, we're not doing the trials. There is a trial on Clinicaltrials.cov where they're looking at interferon gamma, for example, and I saw one looking at IL-17 as well. So I think, you know, your observation is a good one. It could really lead to something.
Okay. Then another question for Bart from Geert van Pottelbergen, who's done his PhD on pentraxins, and he asks, are pentraxins and neutrophil extracellular traps involved in the pathogenesis of lung injury in COVID-19? Are they a possible therapeutic target?
Mm-hmm. I think Geert, again, a very excellent point. So in general, in diffuse alveolar damage and acute lung injury, there's an overwhelming evidence for netosis. So if you measure, like for example, citrinated histones, they are sky high in the bronchoalveolar lavage fluid of patients with ARDS. So I would be totally, you know, totally comfortable with saying yes, you know, you're going to find it. I haven't seen any study so far, however, not that I have seen specifically in this epidemic, but in the previous modeling, you know, in the MERS epidemic and in the MERS animal models and SARS animal models, there's been several reports reporting that netosis is there. You know, how do you treat netosis? You know, you have these so-called DAP4 inhibitors. They haven't been really tried in lung diseases very extensively. Inhaled DNase, for example, Dornase alpha could be something. But again, you know, those are things which I think are you know, quite scary to test it with this degree of severity of disease.
Okay. In the meantime, Jens Staal remarks, I guess antibody treatments might be problematic to do as a short treatment, considering how long antibodies persists.
Yeah, so meaning antibody treatments with biologicals, I guess. That's exactly what we see. So if you give those patients an anti-IL-6 antibody, for example, or the tocilizumab anti-IL-6 receptor antibody, you actually get complex formation. So the serum levels of IL-6 go up in those patients, but the target is neutralized. So you still pick it up with the ELISA, the IL-6, but it's in an immune complex and it's neutralized. So with so much cargo on board, you know, a single shot of antibody will do its job, neutralize IL-6 for probably only a couple of days, and then, you know, you will lose your therapeutic effect. And that's why it's so important that we're doing it early in the disease when the load of IL-6 is not sky high yet. And that's also the difference with other studies that have been done in Italy, where they give 4 times higher doses of ruactamra, of tocilizumab, but that's because they are much later in the disease, you know, and we didn't have that luxury because we were unable to purchase enough drug because it was already running out of stock already early in the beginning of the epidemic.
Okay, then maybe a question for Steven. Like in the former session, there's again a question on BCG vaccination. Amir Bagherin comments that in Ukraine, it's believed that an old BCG vaccine can fight against COVID-19. Could you agree with this? I know there is some data about that, Steven. Can you
There is
comment?
indeed some data that it has some antiviral effects. There's some data on other viral diseases also, in vitro data. Not all of those studies are positive, and there's a lot of data or a lot of non-peer-reviewed papers now circulating that in countries with a high vaccination of BCG, there is less COVID-19. But I would like to warn that in those studies, it's difficult to compare them. They haven't been peer-reviewed, so we have to be very careful with those papers. Finding an association is not a causality. As far as I know, there's no precise mechanism which has been identified for this protective immunity of BCG. And then thinking in the larger picture, BCG is already in short supply in the world, and there's still some very endemic countries with tuberculosis. It's hard to produce, it's hard to get our hands on. So as long as there's no firm data and no firm protection, I would be very careful of using it as not to cause a second epidemic after this COVID of TB in children especially.
Okay. We have a question maybe for Erik Hoste to answer from Tom van den Berge. What is inducing the collateral damage or injury? Is it the virus or ischemia or maybe reperfusion injury?
Yeah, excellent question. And I guess it's both. The virus is hitting different targets, not only the lungs, but I know of kidneys and myocardial tissue also, and liver tissue. So that's one thing. But then the second phase definitely is driven by the inflammatory response, and that's when the patient gets worse and will develop other organ dysfunction. So both phases probably contribute. Toxic effect by the virus itself, but most importantly, probably the inflammation giving a second hit.
Bart wants to comment on that as well?
Right, I think in that regard, Erik, it's also what strikes us quite a lot is that by the time the second wave comes up of disease, that's also the time point when the antibodies start coming. So there is a theory that maybe antibodies could be contributing to the pathogenesis of the disease, through immune complex formation. So I think that's something we need to urgently sort out because of this convalescent plasma trial. And I think it's very hard to say which mechanism at which particular time point is doing what. It's a new disease.
Yeah, there is another question from Geert van Pottelberge on this trial with convalescent plasma. What is your opinion on that? In view of a planned participation in the COVID study, which has been initiated by Bart Reinders from Erasmus MC in Rotterdam.
So you want to comment or?
No, go ahead.
Yeah. Okay. So we've looked extensively into that also in the literature, and in the past we've looked also at the role of immune complexes and antibodies in viral disease. I think until you can really determine that a donor has a good neutralizing titer of neutralizing antibodies, meaning you have to do a test where you have the live virus on a cell line and showing that the antibody can actually neutralize something. There is an inherent risk that you're going to use donors that are maybe serology, that's seroconverted, but their antibodies might be of poor quality. They might be low affinity antibodies, and in those kinds of scenarios, if you then transfer that to a patient, you're actually diluting the titer even further. You go from a single donor to, you can only take that amount of plasma, and then you dilute it in an acceptor. There's actually a risk that the virus will use the antibodies to enter into cells to use the antibody in its own benefit. And this is very well known in the literature as antibody-dependent enhancement. It's been shown many times in viral infection, particularly in dengue and yellow fever. It's also been reported in Zika fever. And, this is a new virus, so we don't know what's going to happen. In MERS, for example, it's been shown that antibodies can make it worse if you give it in the wrong time period of the disease. So I think that's why we need to do clinical trials. And I would certainly do that with a steady, dose escalation, just like you would do with any new drug you're testing in a new disease.
Okay. There's one question from Stefan van Kouwelaert on the SARPAC trial. As the role over alveolar macrophages lies upstream to the cytokine storm, don't you fear to facilitate or lower the threshold for the cytokine storm in some people by providing them with GM-CSF?
Yeah. Okay, that's a question we also got from the ethical committee. So I think you have macrophages, and that's what people don't realize. I mean, we are in this every day. You know, my daily job is working on macrophages and dendritic cells and whatever. So the macrophages that are normally in steady state in our lung are the real alveolar macrophages, meaning that they can clean surfactant, that they can cause T-cell immunosuppression. The monocytes that we're getting into the lungs they are totally different. They are pro-inflammatory cells. They are not acting as vacuum cleaners. They are pumping out pro-inflammatory mediators. They are pumping out complement as part of their production process. They make complement. So something needs to cool down those monocytes. And we have shown this already in the past in mouse models when monocytes come into the lung and they don't have GM-CSF, they stay as pro-inflammatory cells, and it goes terribly wrong in the lungs of mice. For example, mice with influenza virus, where you neutralize GM-CSF rather than giving it, if you neutralize GM-CSF, a mild disease becomes a fatal ARDS-like disorder, and the mice die. So it's very counterintuitive to give a cytokine to treat a cytokine storm, but that's in fact what you're doing. So a cytokine is always the yin-yang, depending on where it's working, you know, and the timing of the response. It can have a beneficial or a bad. But again, you know, the virus is subverting the function of GM-CSF. It's blocking production of GM-CSF.
And maybe to conclude, one last question from Delphine Bogaert. It's a very good one. Could you perhaps elaborate on why children are less affected by COVID-19? Could this be exploited for treatment? I think that's a key question.
All right, so should I? Thank you very much, Delphine. This is, of course, coming from a pediatrician with an immunology background. So, Delphine, I think part of it, and I've read a little bit about it also, part of it is probably found in the type 1 interferon response. So children have a much more rapid type 1 interferon response in their airways. So it could be that they control the virus much better. An alternative theory that I have read is that the elderly population might have pre-existing titers of corona-specific antibodies to other subtypes of coronavirus. So not SARS coronavirus, but the normal coronaviruses that cause common colds in the world population. So in the elderly people, you have higher titers of corona-specific antibodies, which might actually be low affinity binders to SARS coronavirus type 2. And this is exactly what I was saying. It's this antibody-enhanced disease. So those antibodies, which are low affinity, cross-reacting with SARS coronavirus 2, might actually help the virus to enter into cells. And that's also been hypothesized that the elderly have had more exposure, more chances of cross-reactive antibodies, and that could be the reason why they are more susceptible.
Thank you. So to conclude, I would like to thank our audience for the very nice interaction. I would like to thank our wonderful speakers and panel. And also next to the people involved in the setup and the conduct of the clinical trials, I would like to thank all clinicians, nurses, and patients to enable us to make these promising trials possible. And also a big thanks to the communication department and our ICT department for making this webinar possible in such a short time frame. Thank you.